Hello everybody. Today we will talk about rheumatic fever in adults. We will deal with the issue from the point of view of adulthood. And our agenda will include a brief introduction. What's the definition of rheumatic fever? What's the etiology? And the significant pathologic lesion of rheumatic fever, how it affects these different organs, what's the clinical features, how to investigate, how to diagnose, and how to treat. Briefing about the rheumatic fever, it's one of the major causes of acquired heart disease in children and adults worldwide. And when speaking about an acute attack of rheumatic fever in adults, when we should put in mind that it's most probably a recurrence, it's not a de novo attack. Although de novo attacks in adults are present, but yet very rare. So, an acute attack of rheumatic fever happening in an adult is most probably a recurrence of previous attacks. Rheumatic fever affects or counts for about 25 to 45% of all causes of cardiovascular disease in developing countries in the third world. And actually, it's one of the major causes of mortality or death in those population, especially in the age below 50 years. To define rheumatic fever, it's a diffuse autoimmune disease of connective tissue, primarily involving the heart, the blood vessels, joints, subcutaneous tissue, and the central nervous system. What's the etiology of rheumatic fever? Rheumatic fever develop after sore throat which is not properly treated, with a latent period of about 1 to 3 weeks. The causative organism is actually a bacteria which is named Group A beta hemolytic streptococci, or the gas. This is a microscopic feature of the bacteria or the beta hemolytic streptococci, as we can see here. And to the right is diagrammatic structure of the group A beta hemolytic streptococcus concerning the capsule, the cell wall, and the cytoplasm, the contents of the cell wall, and the outer capsule, including the protein, antigen, the carbohydrates, the peptidoglycans, and the cytomembrane. Once that beta hemolytic streptococci antigen is affecting the person and it invades the bloodstream, there is autoantibodies and T cells start to recognize it and perform an immune complex, cross-reactive immune complex. That cross-reactive immune complex, when it happens in the joints, results in transient polyarthritis. When it targets the heart, it can affect the valves, it can affect the it can produce pancarditis, including endocarditis, myocarditis, pericarditis, mainly targeting the valve proteins, and induce valve disease with heart murmurs, which can progress and can be chronic, can lead to chronic or permanent damage of the cardiac valves. And it can target the basal ganglia in the central nervous system together with the dopaminergic neurons, leading to the production of movement and behavioral disturbance, what is so called the Sydenhams Chorea. This is a diagram showing how the group A beta hemolytic streptococci invades the cell membrane of the pharyngeal epithelial cells. Once it's inside the cells and it's encountered in the bloodstream, there is this gas antigen is processed and presented to the beta and to the T cells, which in turn leads to the production and the generation of cross-reactivity and the development of antibodies, an autoimmune complex tackling or targeting the heart, the brain, the joints, and the skin. Regarding the clinical features of rheumatic fever in its clinical presentation usually differs between adults and children. Rheumatic fever is well known to bite children's heart and likes their joints. It's very aggressive in the children, and rheumatic fever attacks occurring in the adults bites the adult's joints and likes the heart. There's minimal affection for the adult's heart, affecting mainly or tackling or targeting mainly the adult joints. So how to diagnose? First of all, we have to take a good history. Regarding the age, it is usually occurring early in life. The juvenile onset usually starts from the 5th or the 15th years of age. It's very rare to be occur in those who are less than 3 years, because they still do not have a well-developed immune system. And whenever it happens for the first time in adults, it's very rare, yet it can occur, and it can occur at any age, of course. It can affect all races, all ethnicities, with an equal preponderance between females and males. It usually happens to affect those people with low socioeconomic standards who are living in overcrowded spaces, poor sanitation, and prevalent poverty. Usually whenever we are taking the history, a good history will usually point that there was an antecedent pharyngitis or bioderma infection, or it might, if in an adult, it may give a remote history of rheumatic fever in childhood. This diagram is used to present the clinical manifestations of acute rheumatic fever and the timing, with polyarthritis and carditis usually presenting early within the first months, and Erythema Marginatum with an peaking also in the first month. Yet chorea might be a little bit delayed with manifestation. It's usually manifesting itself after the second week up to the 6 months. Subcutaneous nodules, if it happens, it is usually happening in childhood, not in adulthood, and with a peaking in the second to third months. In Erythema Marginatum, there is a peaking in carditis and polyarthritis in the first month, in the end of the first months. Regarding, first of all, speaking about the adults having or suffering from a rheumatic attack or rheumatic activity, the first and the most eminent symptom is polyarthritis. And to speak about polyarthritis, it's usually fleeting and flattening migratory polyarthritis. The most common presentation in adults, in about 90% of all cases, are having polyarthritis. And one should say that it's fleeting and flattening. It's very transient. It's like a spark, a flash, migratory, and it goes away easily. It's very transient. It's usually affecting the major joints, those of the lower limbs, the knees and the ankles, more than those of the upper limbs, the elbows and the wrist. Though all are affected in a migratory fashion, in a fleeting and flattening fashion, yet those of the lower limbs are much more affected than the upper one. Considering the small joints, they might be affected, yet the most common presentation or affection is that for the major joints. It should be noted that arthritis is acute and transient. That's to say, they do not progress to chronic disease. Second symptom is Pancarditis. Pancarditis, symptoms of Pancarditis, it means endocarditis, myocarditis, pericarditis. And it must be taken into account that the Pancarditis is the only manifestation of rheumatic fever that leaves sequelae and permanent damage. Pancarditis might present with chest pain, heart failure. It's less common, and if present in adults, it's less severe. Might affect up to 35% of adults having an acute attack of rheumatic fever. Adults without pre-existing valvular disease of preceding attacks seldomly develop carditis in subsequent attacks. So, whenever an adult is having a worsened carditis, or a second attack of carditis, or an attack of carditis in the sequelae of rheumatic activity, it must have been a recurrence, must have been a second attack or a subsequent attack. It is not the first one for sure. Carditis is not common in adults. Fourth is Erythema Marginatum. Erythema Marginatum usually affects less than 5% of cases, where there is unique, non-itchy, transient, serpiginous lesions 1 to 2 inches in size with a pale center and red irregular margin. They are occurring more on trunks and limbs, and they worsen with the application of heat. Usually, erythema marginatum is associated with chronic carditis. Evanescent maculopapular rash. If there is a previous attacks in the adulthood with documented carditis, there might be established cardiac murmurs, worsening murmurs, depending on the affected murmur. And we have to note that none of the adult patients reported to have subcutaneous nodules in the attacks of rheumatic fever. Those developing subcutaneous nodules are usually young in age, are usually children. From the symptoms of Sydenhams Chorea, clinical presentation of Sydenhams Chorea, there is a pronation sign and the jack-in-the-box sign. There is fasciculations and inability to keep the tongue inside the mouth. Always the tongue is loose and is flaccid and thrown in and out of the mouth, and there is usually milking sign of the fingers of the hands. It's one of the signs that is usually present in Chorea. How to investigate? First of all, we are having the labs. We are now having in front of a case that I'm suspecting it to be rheumatic fever or to have rheumatic activity. What's next? This is an autoimmune disease affecting the connective tissue mostly affecting the connective tissue. So one should search for the inflammatory markers. There will be high C-reactive protein, high ASO tetra, mostly more than 400 touch units, with a peak value occurring at 3 weeks, then it comes down to normal by the 6th week. High ESR. Looking at the CBC, there will be anemia and leukocytosis. One should have an anti-DNase B test and a throat culture for the streptococci antibody. Doing an ECG is one of the simplest and is one of the very important investigation in the cardiac patient. There will be tachycardia denoting the infection, yet there will be a prolonged PR interval. Looking at the X-ray, there might be nothing at the X-ray if there is an acute attack without any previous cardiac involvement. But if there is a previous cardiac involvement with previous valve affection, there might be cardiomegaly, there might be pericardial effusion. Ordering an echo, it might reveal a pre-existing valvular heart disease, mainly affecting the mitral valve, from mitral stenosis, mitral regurg, aortic regurg, aortic stenosis, and whatsoever, and the drawbacks of that valvular affection from chain of involvement. How to diagnose rheumatic fever? We are having major criteria and minor criteria. As we can see previously, as we have seen previously, that the major criteria are the polyarthritis, Pancarditis, Erythema Marginatum, Sydenhams Chorea, and in children the subcutaneous nodules. The minor criteria were arthralgia, prolonged PR interval, fever, elevated ESR or CRP, elevated ESR or CRP. So whenever an attack of rheumatic fever, one should have 2 major criteria or 1 major and 2 minor criterion, plus evidence of pre-existing beta hemolytic streptococcal infection, which is the same for the diagnosis in childhood as well. Again, this is a table showing the major criteria for the revised Jones criteria: carditis, whether the carditis is clinical or subclinical, arthritis, monoarthritis or polyarthritis, chorea, subcutaneous nodules, which is not present in adults, erythema marginatum, and the minor criteria: arthralgia, fever, ESR more than or equal 30 millimeter per hour, or CRP, elevated CRP, a prolonged PR interval after accounting for age variability. How to treat? Step 1, when dealing with rheumatic activity, we should have 3 concerns. Treat the acute event, prevent it from happening, and treat the complications. First, treating the acute event. Rheumatic activity or an attack of rheumatic activity occurring in adults mostly is presented with polyarthritis. Dealing or treating the polyarthritis in adults, step 1 is anti-inflammatory treatment, either with aspirin or non-steroidal anti-inflammatory. Aspirin, regarding the revised starting dose, is 50 to 60 milligrams per kg per day, and it should be tapered as symptoms improve, continued for 1 to 2 weeks after the symptoms resolve completely. And one should take into consideration that there will be rebound symptoms with rapid tapering or early cessation. So we have to continue for 1 to 2 weeks after complete resolution of symptoms. In some people, we can give non-steroidal anti-inflammatory, and the effectiveness of naproxen has been reported in adults with the same efficacy to aspirin and a lower GI adverse effects. Step 2, supportive management and management of complications. In case of adults with an acute attack of rheumatic fever, it's tackling mainly the joints. It's mainly polyarthritis. So rest the joints and supportive splanting. The management of complications, management of residual valvular heart disease, if there is valvular regurgitation and or stenosis, if we can give a prophylaxis against infective endocarditis so as this might not happen in the future, should be taken into consideration. And the tertiary prevention is prevention of the recurrent attacks. Prevent the recurrent attacks or the coming attacks by a single injection of 1.2 million units of bendazine penicillin G every 2 to 3 weeks, or a single tablet of 500 milligrams of sulfadiazine 2 times a day, or a single tablet of 250 milligrams potassium penicillin 5 2 times a day with an empty stomach, or if allergic to penicillin, give 1 tablet of 250 milligram erythromycin 2 times a day.